Welcome to the first of a series of discussions around ethical dilemmas in healthcare, hosted by the Jerusalem Ethics Forum, the Cura Foundation, Galian Foundation, Elie Wiesel Foundation, and M Health Israel, brought to you by Allison Partners and supported by Finn Partners. Today we'll be talking about COVID-19 with respect to ethical issues that have arisen around providing care at an individual level, the social disparity of healthcare, governments mandating movement restrictions and quarantines, and the overall preparedness of addressing the pandemic globally versus country by country and even city by city. And today we have with us three esteemed global leaders, Dr. Zeke Emanuel, Professor Philippe Douste-Blazy, as well as Monsignor Tomasz Trafny from the Vatican. It should be a thought-provoking 45 minutes, and we appreciate your participation. Now let's begin. Even though brilliant minds such as Bill Gates in 2015 said that we weren't ready for a pandemic should one occur, we still didn't do enough to be ready for SARS-CoV-2 virus. Dr. Emanuel, how would you rate our preparedness on a scorecard, and what should we do to protect ourselves from a second wave of COVID-19 or any other infectious biologic?
Well, I would say that we generally got a C. Let me make a few points. First of all, we should have been prepared. I began working on pandemic preparedness in 2005. That was pretty soon after SARS, people will remember. The new Secretary of Health and Human Services in the United States who came in, Michael Levitt, saw that we were unprepared and asked the Department of HHS to develop a pandemic preparedness plan. And they did that. They had some weaknesses in that plan, especially when it came to the ethics of distributing ventilators and vaccines. We criticized that, and then I began working on allocating scarce resources during a pandemic. I used to teach a course at Penn on rationing and resource allocation where pandemic preparedness was a key feature. And I often emphasize that, the last influenza pandemic we had was in 1968, and we were long overdue for another one, but we were not very well prepared for it. And I think despite SARS, Zika, Ebola, MERS, H1N1, we didn't do it. And there's I think a sort of human characteristic that adds to not being prepared. These are low, but not zero probability events. And while their harm is pretty substantial, as we're experiencing with COVID-19, the probability is low. And as human beings, I think we don't do a good job with big harms, but low probabilities. We say, we can deal with that later because the chances are low. We tend to underinvest in that kind of preparation unless you really have a lot of foresight and discipline. And what we've seen around the world is that's exactly true. We've underinvested in general. Not every country. Two countries that have done a remarkably good job, South Korea and Taiwan, they invested heavily because a lot of these viruses originate in China, and they were fearful of their proximity to China, getting information from China and things like that. And they did prepare extremely well, and they have benefited, as we can all see, from that preparation. I think Taiwan has had a maximum, despite being so close to China and with a lot of exchanges, they have had 500 cases and I think less than 10 deaths. So preparation does make a difference, but psychologically, we're not a species that is well prepared for these kind of events.
Professor Douste-Blazy, you've been Minister of Health in France twice. What immediate lessons do you draw from this epidemic?
So I think that each major crisis reveals the state of the society, but also the state of civilization around the world. So the first observation we made during this COVID-19 crisis is that most countries were not ready at all. No mask stocks to protect themselves, no test stocks to screen, no organized and coordinated systems to isolate the patients, to avoid the contagion of the disease. So the mortality rate in France for COVID-19 will be much higher than that of countries which have been able to massively test and isolate patients immediately. So officials will have to provide explanations. We are going to have commissions of inquiry in France to find out the truth. And these officials will soon have to come and explain their discrepancies. This is all the more inexplicable since I presented to the Council of Ministers in 2004, when I was Minister of Health, a plan to fight a pandemic. So why didn't we activate this plan? Are there people in this country who are naive enough to hold the disappearance of epidemics as established for eternity, and to deduce that all precaution is unessential? So the recent epidemics have reminded us in our European latitudes how many and fearsome are tuberculosis, poliomyelitis, smallpox, not to mention the annual epidemic of flu. So we all have to remember that.
So, you know, it's a very good point when we look at all of this. And I want to go back to something that you just said, Dr. Emanuel, about prioritizing of care. There was such an onslaught in Italy and Spain and France of sick people coming to the ERs and the hospitals all at the same time. And there isn't enough resources. So people used age to say a child should get the ventilator over an adult, or an adult should get a ventilator over someone elderly. You know, we took an oath to do no harm. So how do you do that? How do you take care of everybody when those resources aren't there?
So first of all, I think it's really important to understand that situation of what is termed absolutely scarce resources. Absolutely scarce resources are ones where you don't have enough for every person who has medical need. And a choice is forced upon you, not willy-nilly, but by nature and by the shortage. Over time, over history, we've faced such shortages. When we initially developed insulin in 1920, there was a shortage because we couldn't produce enough. When penicillin was initially developed in the 1940s during World War II, similarly, there wasn't enough. You had to ration among people who could benefit from it. When chronic dialysis was initially developed, we also had to ration because there just weren't enough machines until we financed more developed machines. Similarly with HIV drugs initially. So this is a case, not that people are deciding or doctors are deciding some people won't live. This is a case where nature is forcing these kind of decisions. As I said, in 2005, 2006, I initially got started in looking at the ethics of allocating resources that are scarce. Organs for transplantation is another good example. And we have recommended using age as a criteria where appropriate. It's not the first criteria. The first two criteria are maximizing the number of people saved, but also maximizing the number of life years saved. And I have done informal surveys. I've given talks on this to hundreds of audiences in many, many different countries. And almost invariably, the intuition of people is exactly the same, which is you save younger people over older people. And I think that intuition comes from, look, an older person has had a full life already. A younger person is just beginning. If they have the same prognosis, they have the same chance of recovery, you want to give the younger person an opportunity to live a full life. I think that's the intuition. It's not because the older person isn't valuable. They're valuable too. Everyone's valuable. It's just that what we want is to allow people to live a complete life. And I think that's a very powerful intuition that people have, and that motivates this look at age when other things are equal. Prognosis is equal, the number of lives you're going to save are equal, and things like that.
Monsignor Trafny, from a religious perspective, how do we reconcile making those choices and possibly leaving some people behind?
First of all, I think we need to say that the situation of pandemics is a very particular one. Even in such dramatic context, it would be unthinkable to leave someone behind intentionally, like it was said before. And this is particularly true to the healthcare practitioners or in healthcare institutions. I would rather think that usually we are not prepared to deal with such dramatic situations. In normal context, many healthcare institutions develop and follow patient prioritization tools, which help physicians and decision makers to manage access to care. But preparing to this meeting, I went through some papers, and what was said before is true, that in some studies suggest that within the context of limited resources, the healthcare practitioners tend to adopt the utilitarian approach, prioritizing, for example, children, young individuals, married women, instead of, for example, elderly person. And this is very common, and especially when people have to act or behave or work with this particular context of scarce resources. But, from religious point of view, we do not make distinction between the value of elderly person or infant. All of them are equally important. Moreover, we prioritize those who are vulnerable, who are fragile. And in this case, for example, many often this utilitaristic approach would not be, let's say, acceptable. But pandemics context, by analogy, is similar to the wartime, when people are exposed to the severe threats and they are operating within the context of scarcity. And in this case, by many reasons, people tend to save, to optimize resources they have, and definitely they would prioritize some people instead of others. In Judeo-Christian tradition, our life on earth has not an absolute value. But for this reason, it is very important to accompany those who suffer, to help them, because this is a situation of extreme stress, both for patients, but also for healthcare providers, let's say physicians, nurses, and the entire staff. So for this reason, I think it's important to provide for some spiritual, psychological assistance that will help them to manage this situation. Because to make choice between those who has to be saved and those who will be left behind is also a huge psychological burden for those who are called to cure and to assist them.
Can I just, there are two things. So first of all, there are many reasons, I think, as the Monsignor said, to support the idea that the young should be saved in preference to the old in absolute scarcity moments. It's not just utilitarianism. I don't mean to be pedantic about it, but there are almost everybody believes that, regardless of their philosophical or spiritual or religious affiliation, it's not just utilitarian that we're maximizing the greatest good for the greatest number. It's many, many different ethical traditions accept that notion. And so I think, I don't want people coming out of this to say, oh, you're a utilitarian if you believe that. That's just not true. You can have lots of different philosophical views, including helping the most vulnerable. And in this case, children who haven't lived a whole life are among the most vulnerable. The second thing I would like to say, and I think Monsignor has put his finger on something exceedingly important, the psychological burden of making these choices is enormous. And I think the system recognizes that we have a lot of psychological burden on healthcare workers providing these kind of choices, but I don't think we've been very good at addressing or figuring out how to address that psychological burden when they are confronted with this onslaught of decisions about who to save and who not to save.
Hopefully at the end of the 45 minutes, we'll come up with some guiding principles that people can think about, because it is very, very challenging, certainly to people on the front line. I'm talking about resources. Obviously, we don't have enough resources, but also there's been a real difference in disparity of health. And clearly the poor have had worse outcomes. They can't quarantine. They don't even have summer homelessness. There's no place where they can self-isolate, and they have nowhere to go. So how do we look at this? And maybe to start with Professor Douste-Blazy, on an international perspective, do you consider, that we're making the right response? Is it relevant for all of people, or could we be doing better to make sure that we meet all of our constituents?
Yes, the second obvious observation of the interdependence that exists between us with today's means of transport, especially the air transport. All human beings are within reach of each other. So in addition with this crisis, COVID-19, we have never seen international solidarity, zero. Everyone believed that its national interest was to resist the local government team. On the ethical level, we must defend the idea that health is a global public good, as food, as education, etc. That it is a fundamental right for every human being in the same way as water, food, education. We must draw conclusions for the governance of the WHO, the World Health Organization. Why is WHO ineffective? Because it has no forcing means. We must provide the WHO with binding powers as we have for the World Trade Organization. We have managed to do for trade. We have not been able to do so for health. So how can we think that it does not take a global COP to ensure that all the countries worldwide are well prepared if an epidemic arrives? The health of the world's population is at this price. One day, one epidemic will arrive with a more contagious and more virulent virus, and no one will forgive politicians for not being collectively prepared. The other major ethical issue is the universal access to anti-COVID-19 treatments or vaccine worldwide. Indeed, the vision of this new world order must lead to a voluntary policy of manufacturing affordable, and I repeat, affordable medicines and vaccines for all populations, including the poorest.
Dr. Emanuel, do you have thoughts on this?
Look, I couldn't agree more that we do need to ensure that we have a universal response. One of the, I think, unfortunate facts is that COVID-19 has come at a moment of divisiveness in many countries, of populism, which is built on divisiveness in many countries. Certainly in the United States, as I think in many other countries, we see that the poor immigrants are particularly hard hit by COVID-19. There are many reasons for that. One is they have a disproportionate number of comorbidities, whether obesity, diabetes, hypertension, and they certainly experience a lot of that, which puts them at higher risk for adverse events from COVID-19. Second, I think, as the professor mentioned, often the housing situations make it hard to socially distance and to create separation from other family members who might be positive, as well as other people in the community. There's just simply more density, and more density facilitates transmission, and that has been a serious problem both at home but also in the work environment. We in the United States have experienced these outbreaks in meatpacking plants. It's not because of the lifestyle of the meatpacking workers, it's because of the way the plants are structured and operated, that people are working close together. There's no real separation. It's a cool environment that facilitates transmission of the virus. So we need to examine all of it. And finally, we need to ensure, I think, as the professor adequately said, universal access. Now, initially, a vaccine or a therapeutic will not be universally accessed to 7.5 billion people across the globe. How we ration that, like how we ration resources in a country, is going to be a challenge. And that, I think, is an even bigger challenge, because at least in the country, everyone's, a fellow citizen. Around the world, as the professor has mentioned, we've had a lot of divisiveness rather than unity. And what we need is unity, and we need strong international leadership to bring the world together, not to divide us country by country. That has been unproductive in many ways, and it'll be unproductive when it comes to a pandemic. And it'll make it harder to address rather than easier to address.
And do you think education is a way where, instead of mandating differences, the restrictions, that we can help educate people to be more responsible, so that you're helping, everyone is doing their part in the spread, as opposed to mandating the serious restrictions that we're seeing?
So what we know from behavioral science is that you can get a lot of adherence by social norming, by creating the right norms. Make it easy for people, for example, to wear face masks, to social distance, making it actually the social norm that, celebrities do it, politicians do it, everyone does it. One of the things we know about people is, how are we supposed to behave? Well, we look around us and see how other people are behaving. And if 99% of the population is wearing a mask, guess what we'll do? We'll wear a mask. And so I think that, and you don't need a law for that. That can just be, if the masks are free and everyone else is wearing a mask, I'll do it too. And I think that kind of social norming coming from the top is really important.
Lead by example.
Absolutely. And it's really important in a pandemic where, the last thing we want to do is to be paternalistic and say, you don't wear a mask, we're going to fine you thousands of dollars. That's not really effective. Norming, making it free and norming it is, I think, a much more effective technique.
And Monsignor Trafny, certainly the Pope has taken that stance, obviously used to large gatherings, certainly at Easter and his masses, and really has encouraged people to stay home. They've closed the churches. How do you continue to serve and be there as a resource under these circumstances?
Definitely, sometimes it's very difficult to draw a clear demarcation line between the necessary prudence because of possible threat and the right to exercise our faith. And I have no doubt that if we would live in medieval time, we would see a lot of people gathering for religious processions and celebrations. And I think that the history taught us a very important lesson, and we are dealing with a very new situation. The COVID-19 phenomenon is still subject to studies that seem to fully understand it. And that is why it seems wise for now to make the principle of prudence prevail. However, it should push us to find new ways to accompany those who need spiritual support, to assist them. And I can see that many pastors, many priests, rabbis, spiritual leaders are searching for new ways how to reach their followers and how to assist them correctly in this particular situation. And I think that until we are investigating, the scientific community is investigating on this virus, we need to be prudent and we need to be patient also, even though sometimes it's very, very hard to do. And of course, what you are asking before for the situation of poor people, homeless people, this is very difficult for all of us. But this is also a opportunity to collaborate between state and religious institutions, because together they can play an important role providing for suitable structures where to stay and be assisted. If people would accept that, because we know that many people, even though they are homeless, they have difficulties to enter in a specific institution because it means to accept certain rules of social behavior, and not everyone wants to do that. But it is an emergency. Only in Italy, the estimation is that we have about 50,000 homeless people, and approximately at least 8,000 only in Rome. So those situations cause a particular, I would say, attention, and we need to address that. And I think that this is a very good opportunity for the state institutions and religious institutions to collaborate and to find out how to address these issues and how to help those in need, especially poor, especially homeless, especially those most vulnerable.
And Professor Douste-Blazy, what do you think is the best approach for citizens to join collective measures as opposed to their expectations in times of crisis?
The consensus about the crisis is also to the behavior that each of us should have towards others. So greet without check-handing, keep a minimum distance from others, put on a mask, stay at home. These measures are difficult for people to live with. So, but they should not be seen as sanctions and have to get them acknowledged with good pedagogy rather than using constraint. What is possible in a dictatorship is not possible in a democracy. So we must take into account the different communities as well as social data. It is obvious that it is more difficult to respect confinement, lockdown at 10 in an apartment of 45 square meters than at 3 in a beautiful house. This is the reason why the type of health crisis doubly affects the poor. Firstly, because, as the professor said, intra-family contamination is higher there. And secondly, because poor people have much less access to health than wealthy people. The observation leads to the establishment of strong, stable ethical criteria to protect the weakest and to guarantee them of both access to care and treatment. The consensus about the crisis is also the behavior that each of us should have towards others. So I think it's my answer.
Dr. Emanuel, so we're forcing the restrictions that are forcing people to stay at home, jobs to be lost. Are we not choosing people's exposure to COVID, which they may contract and they may die from it, versus ending up possibly homeless, or having hunger, malnutrition? Are we making that choice for them?
we are doing or we're having our governments do what government's supposed to do, which is to protect people. In the United States, we're past 85,000 deaths. By June, we're going to pass 100,000 deaths. It looks like by the end of the summer, we'll be well past 150,000 deaths. That's an enormous number. Government has to protect us from that. Simultaneously, we do need to find ways of taking acceptable risks and opening up normal social and economic activities. And I think that's a balance that lots of people are trying to find. How do we develop a protocol that allows stores to open, restaurants to open, schools to open? And this is new territory. We, I think, have learned a lot in the last 2 months. For example, transmission mainly in a confined space where you're near other people and you're rebreathing air, because the main transmission is high virus volume over a prolonged period of time. And that happens in confined spaces where people are breathing, mainly sneezing, coughing, and singing, expelling a lot of virus particles over time. So there are things we can do in summer, and in countries that are warmer, we have a lot more outdoor activities. So let's use the outdoors and facilitate that. We need to redesign spaces so that we can respect physical distancing and separations. So these are the kinds of creative approaches we're going to need to reduce the risk. We're not going to get it to zero, but to reduce the risk of transmission. We also need to recognize that we need to be vigilant and be very protective of people who are at higher risk, older people and people with comorbidities. And that's just a critical factor. And I think, again, many countries have not done a great job of that. And countries that have done a particularly good job, Germany, for example, have seen a pretty low mortality rate by focusing in on protecting the most vulnerable. So I think this is a balancing act. Everyone wants to get back to work, but this idea that seems to be circulating that, you don't need to close restaurants, you don't need to close bars, we shouldn't have closed down businesses, just false. Even the one case they point to, Sweden, just a sui generis case, and it hasn't gone well. It is a country, as I mentioned, that over 50% of the population lives alone. Well, that makes it easier. Two, they have a low rate of comorbidities. Three, the rest of the country outside a few major cities is very dispersed. The number of people per square mile is low. Nonetheless, Sweden has had a very high mortality rate, much higher than its neighbors, Norway, Finland, Denmark, Germany. And its GDP, it's not like its GDP is hunky-dory. It's going to estimate to go down for the year 7 to 10%. So letting the virus out is not the solution. Almost every responsible economist will tell you the best way to fight this virus is a double-barrel thing. Top list, 1 through 5, public health measures. Reduce the transmission, give confidence to people that if they go out and engage in activities, they're not going to get sick and potentially die. And then give people enough money to sustain their life with food and other things till we get to a place where we have a vaccine or effective preventatives. And that's the solution. Unfortunately, people would like to race ahead. And I think have been doing it, and certainly in some places, and not a very responsible manner.
So take your time and be measured, but there's hope out there. It's not keep things closed till 2029.
We can't keep closed. Well, even end of 2021, we can't keep closed that long. We need to have activities, and we need to recognize, look, I'm not a big sports fan, but I think returning sports is, especially to TVs, is really important. Because lots of people are sports fans. It's a symbol of returning to normalcy. People like engaging in it. Similarly, with schools, really important. Kids need socialization. They need activity. Their parents need freedom so that they can concentrate on their work. I mean, there are lots of things we need to do. Filming for media. So we have new movies and new television shows. Again, I'm not a big fan. I don't own a TV, but I think it's really important for normalcy in our society.
And normalcy may change. A perfect example in sports is esports, right? People are moving more towards other ways to still have competitiveness and maybe new ways to add that in. So, Monsignor Trafny, how about religion, right? How might that change in the future? I mean, to be able to worship, to feel that you're not alone, to be the guiding principles of even togetherness and family that we often see in celebrations like Easter and Ramadan celebration when it's over. How is that going to change to really be protective to the public but supportive as well?
Well, that's a very hard question to answer because we don't know how it would impact our spiritual life or, let's say, institutional religious activity. Definitely some elements will change. And unless we will take under control the situation, many restrictions will be a referential point for pastors and religious leaders how to behave and how to act. How it would develop, we don't have an answer right now. But probably we would need to restructure some activities and also to think deeply how to be close to the people in need. But at the same time, I think that we need to find balance between emergency and the need that people have. And the difference between, social life, in democracy, for example, the difference between democracy and dictatorship is that there's a balance between individual and collective freedom. Individual freedom is not the highest value of the democratic society. So there are situations when we need to step back and to, let's say, not to deny, but to acknowledge that we have to limit ourselves for the good of others, to protect others. And this refers not only to work life, economy, and let's say social activities. This refers to all aspects of human life, also to religious or spiritual dimension. There are situations when we have to be particularly aware of this context, and we need to adopt ourselves. And in this sense, I think that we would need to educate people over time to perceive the reality differently, like they used to do that. And I think that in this context, I think for the first time I found useful advertising. At least in Italy, there's a lot of institutional advertising that is making people aware of measures that will help them to prevent the spread of the disease, of the virus. This has an impact on our life, but it's one of the most positive impacts that I can see that people are learning from this, not to, let's say, to put money to the system, but simply to behave better, to be more aware of others. And I think this will change our way of living and our way of perceiving the reality, which is completely new.
And Professor Douste-Blazy, what would you say we should implement tomorrow? We heard a little bit about going forward from Dr. Emanuel, how to proceed. As far as consequences for our health, what should we do tomorrow?
So, you know, today most countries are developing a curative and individual health policy. You are sick, I am a doctor, you come to see me, there's a discussion between two people. A trusty relationship for the patient, a relationship of conscience for the doctor. So this is the usual approach. This acute COVID-19 health crisis shows us that we must also develop preventive and community medicine, a medicine which plans to protect the population from collective risks. So not only individual, but collective. This is true for a pandemic, but this is also true for diabetes. In example, it is better to educate children that eating sugar, such as sweets or sodas, can lead to obesity and then type 2 diabetes. This is important for them individually, but this is also very important for the country. So this is where we come to the political aspect of the crisis, and where the loop, you know, I think it's very important to go from personal and individual and curative medicine to a collective and preventive medicine.
Great. Well, I want to thank each and every one of you for being with us and helping to give some guiding principles of what we learned and going forward, things to think about. And we hope all of you will join us next time on our second ethics forum. We will be discussing the shift in the regulatory paradigm during a pandemic and the ethical considerations around finding treatments for patients. Please register by clicking the link below the video. Thank you all.
Thank you. It was a privilege to be here.
Thank you very much. Thank you.